Hi everyone, this is Molly. I am today's September 21st for our web conference, so I just wanted to talk about a couple of things. So our team today is going to consist of Tammy, Morgan, myself, and Rachel Sanchez. A couple of updates or notices. Continuing education. To qualify for CE, please remember you must attend 50 minutes of educational content. An email will be sent to all attendees to qualify for CE within 24 hours of the webinar, ending with instructions on how to claim those. If you have any questions after or at any time during the webinar or post-webinar, please email your questions for verification at the cotvrc@facs.org email address. So our goal for this webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, and understand the processes and standards involved in an ACS trauma verification site visit and how following these will positively impact the quality of care of the injured patient at your trauma center. So let's get started. So just for some folks who are new to our process, if you have a copy of your Orange Book or a PDF copy downloaded from the web page listed at the bottom here. Just also some couple of updates. We have posted the most current clarification document, version 8, that as well. I will be releasing in another update here, possibly today or in the next few days with the next edition, so please be on the lookout for that. If you don't receive it, please email us at the cotvrc@facs inbox, and we'll get you on our list. The recording of this webinar are available on our webpage at the resources, so it'll be available later today or possibly tomorrow by the latest. I'd like to read our disclaimer. All questions are pulled directly from the questions submitted through the portal. There have been no edits made to the content or any misspellings. If your question is not answered today, the question is either a duplicate or requires more information, which I will follow up with you following the webinar, or possibly before the webinar I may have followed up with you. Any unanswered questions will be answered within a week after the webinar. A couple of announcements. So TQIP conference is still open for registration, which is taking place November 5th through the 7th in Orlando, Florida. Our keynote speaker is Dr. Wayne Meredith, who has served as the medical director of the trauma programs of the American College of Surgeons from 2006 through 2010, and was the chair of the Committee on Trauma from 2000 to 2006. We also welcome our special guest speaker, trauma survivor Brian Boyle. Brian's story about catastrophic and transcending all odds has initiated new and innovative strategies for improving patient safety and quality of care on an international level, and serves as a great learning experience for healthcare providers. More detailed information about our meeting program, registration, and travel information can be found on the TQIP annual meeting website. So a couple of reminders about scheduling. I'm going to hand this over to Rachel.
Good afternoon, everyone. As Molly mentioned, I'm just going to go over some scheduling reminders and some tidbits. Starting off, in regards to site visit application, if your center is planning to have a site visit, the application must be received in our office at least 13 to 14 months in advance of the requested time frame or current expiration date. And this basically holds your spot. And couple reasons. Basically, it's due to the office. For example, once capacity is hit, we close that month. And for example, currently the months of January 2017 through July 2017 have been closed to scheduling, and August has a few spots available, and September has been closed as well. So it leaves October, November, December open for visits. And also, in addition to in addition, the lead time is required to help centers prepare and complete the online PRQ, whereby logins will be provided upon receipt of the application.
Just for clarification, for some of you that are new to the verification process, when Rachel talks about closing out the month for this year, all of 2017, or I'm sorry, 2018 is still available as well.
Okay. Then in regards to site visit application payment, when you send in your application, we're asking that you do not submit payment. Because 60 to 90 days before your visit, your center will be invoiced for the quality program fee. And that would include both the site visit fee and the TQIP fee. Then centers will then be invoiced annually for the quality program fee for the remainder of the verification cycle. And then, of course, this doesn't include additional visit-related fees such as additional reviewers. And you can find the fee structure. It's located at that link below. So site visits are typically scheduled within 90 days prior to the requested time frame. And so I stress typically because sometimes it's earlier, and sometimes when it gets down to the end of the month and there's a couple site visits that that need to still be scheduled, it gets a bit challenging. So therefore, it can sometimes go a little bit past 90 days. However, if it's after 90 days, you can definitely send me an email to check on the status, and I'll get back to you. And ideally, all visits will occur during the center's preferred time frame. It's really helpful if you have dates to avoid, if you could let us know ahead of time. And then when a lead reviewer is available for your site visit, I'll send an email to the TPM prior to confirm the date, so it won't be a surprise. I just definitely want to make sure that your center is still available on the dates that we're requesting.
Thank you, Rachel. So we're just going to move along to general questions. Efficiency per se, but more of a clarification on what we're asking for in terms of our, for example, our geriatric population, or questions related to the PRQ. So the first question we received has to do with geriatric population. There's an increase in this patient population, as many of you know. The question here is asking, what is the age range for considering a geriatric patient, and how much of the criteria need to be written down, placed in a binder for visits? So it's two questions in one. So I'll start off with the cutoff age varies between 65 and 85 years of age, and this is noted in the Orange Book. Again, your trauma center may have a different set of criteria, but this is what's printed in the Orange Book. Again, it's not a requirement, it's just a recommendation. The second question was about what is needed during a site visit. So during a site visit, if the isolated hip fractures are part of the non-surgical admissions totals, you'll be required to pull medical records for that category. Please refer to the review agenda. So many of you are familiar with the review agenda. If you're not, it's located in our resources website. There is a section on non-surgical admits, and we do ask that you pull those if you're going to use your non-surgical admissions as part of your PRQ data and your volume requirements. And then part of the question had to do with whether or not they can speak to this, or do they need to have something available on site. For something like this, again, they're going to look at it during the case reviews, and you can also speak to it. So you can do both, but basically you want to have something on site to demonstrate to the reviewers that you are in compliance with your admission criteria. A couple of slides on PRQ. There was a question about what TQIP data would be incorporated into the PRQ, or pre-survey questionnaire. We've talked about this for a bit in the last couple of years. Currently, we don't have any specific plans for this right now. We are working to update our PRQ, say within the next year or so, to incorporate some TQIP data points, but currently there are none. So hopefully in the next year or so we will have that programmed. Question about codes. Question about, there is a section in our PRQ that asks for ICD-9 codes, and we're going to go ahead and update that to also include ICD-10 codes. Currently, the NTDS accepts both the ICD-9 and ICD-10. However, beginning ICD-10 will be accepted. So for those centers currently converted to an ICD-10. There's a slide here that will talk a little bit about what is to the National Trauma Data Bank website for more information. So a question about, are all compliance, or are all sites expected to comply with the Orange Book standards? Ideally, you want to be in compliance with all the standards at a site visit. Obviously, if it's a consultation visit, it's expected that a majority of the standards are in compliance. However, if not all standards are in compliance, it would be cited as a deficiency in the report. It's just a part of our standard operating procedure. Even if it's partially implemented, it's still going to get cited because what the and for a verification visit, all standards must be in compliance at the time of the site visit. So if there's any standards are not in compliance, they will be cited as a deficiency during a verification, and it can impact your verification process. Question about performance improvement plan. In the review agenda, it does talk about materials required at the time of the site review. There's one about trauma program performance improvement plan, and they want an example. So for the person who may have asked this, I do have a little bit more information and do have an example. You can reach me by the COTVRC@facs.org inbox, but ideally what the plan should include, but it's not inclusive of a process for the care of the trauma patients, identify opportunities to improve and implement actions to correct recognized shortfalls, and review current scientifically all-encompassing evidence-based practice for implementation. So you need a plan of how your trauma program is going to work. More questions about the PRQ, reporting year. For purpose of pulling medical records, as noted in the review agenda, the medical records should not be older than 14 months prior to the scheduled site visit. For example, and I know Rachel provided an example of this, if your site visit is in January 2017, the reporting year may be one of the following. It could be October 1st, 2015 to September 30th, or November 1st to October 31st. Reviewers typically do not want to see data older than this. However, if you have any medical records that process a good change or a bad change, whatever it may be, you certainly can pull that and demonstrate that or present it to the reviewers. They typically like to see things like that. Question about appendix for locum. So we've had several questions on locum. Question about whether or not they need to meet the same standards. Yes, they do. So locums are trauma surgeons who take partial trauma call are required to meet the 50% attendance requirement. And I know some folks are talking about where they're only there once a month, or they're there twice a month, or what have you. There's an alternate to this. They can attend in person, they can attend by video, or they can do it by teleconferencing. So there's some options for them to do this. And during the site visit, the data is reviewed retrospectively. So What I want to say about this is if the center had locums during the reporting year and are no longer present, do not list them in the appendices. Only list locums that are currently practicing at your centers. I've seen several centers get cited for a deficiency on this, whether it be CME, whether it be PIPS attendance or board certification, because they had locums working during the reporting year but left 6 months after they started and are no be coming back. Do not list them. They will be cited as a deficiency if you list them in your PRQ. PRQ question about adult versus pediatric data. So in the PRQ, and this is a little confusing, so I'm going to have this slide available, and we are going to address the PRQ to match this. Right now there are there's some typos in there, but we're going to go ahead and address that. So trauma center who admits just adult trauma patients, and the following sections should not be displayed. So if you're a level 1, level 2, or level 3 that only admits adult trauma patients, the pediatric trauma surgery section should not be displayed. If it's displayed, you want to skip that entirely. For those trauma centers that admit adult and pediatric trauma patients and are not seeking pediatric verification, you are only required to complete Section B, the splenetic injury table, Section C, pediatric trauma admission, the entire section. And I also want to stress that you want to only enter your pediatric data at this portion. So again, for the adult and pediatric trauma centers that admit both, you're either seeking or not seeking verification. In the first section, Section 2, you do want to capture your adult and pediatric data, and then you're going to separate that in your pediatric trauma surgery section. Bullet number 2 talks about the center that admits adult and pediatric trauma patients and is seeking pediatric verification. You must complete all of Section 10. We're talking about your trauma medical director, a few questions about that that's not also captured in Section 2. And your trauma program manager and ICU and your PICU. So it does contain all those questions that are not captured anywhere else in the PRQ. So just specific for pediatric. Question about registry and burn patients. We do have a chapter in the book about burn, but what I want to talk about is how we want to capture this in the PRQ. So burn patients who are transferred externally to a burn center or internally to a burn service should not be counted in the total trauma population for your PRQ. The center may include those patients in the trauma registry, but will be required to exclude them for the PRQ purposes. Burn patients with any associated trauma injury should be included in your trauma registry regardless if transferred externally or to a burn center or to a burn service. So they should be counted if they had a traumatic injury with their burn. A couple of questions about neurosurgery care for level 3s. Not a lot to talk about this right now. We're going to go ahead and talk to our chairs about clarifying this for some level 3s that are keeping and maintaining their neuro patients who either have an ICP monitoring, and I will go ahead and circle back on this at next month's webinar. We're going to move on to CD-related questions. So the question was asked about a registrar taking AAAM medicine, so I'm going to go ahead and have Tammy address this.
Hi, so the question, what is the registrar has taken the AAAM AIS injury scaling class, and they fell twice. And so I just wanted to let you guys know that I've been contacted by some members of the AAAM board, and they've contacted me into concern. And so one of the things, this is a really good question, and we're certainly going to try our best to change it, because one of the things that this is a problem with the quality of your data, and that's the whole reason why we required this course, is is we want the data to be good and clean, not just for us at the National Trauma Data Bank. It's the data that you use for TQIP. It's the hospitals, and if you're a level be good, clean data. You want your registry staff to follow the definitions. You want them to be able to code to the best of their ability. And failing this test twice, it isn't really, giving your data a chance. And so here's what I wanted to talk to you about. Right now, until this is changed in the Orange Book, I'm going to give you the charge, you trauma program managers out there, I'm going to give you the charge to stay on top of your registry and the staff and the data that they're producing for your center. And right now, this has to be up to you what you do with that registry staff member. Now, the concern that was brought to my attention from the AAAM staff was that they've had some registry abstractors that come through the course, and they don't really want to be there. They don't really care, and not participating in the course while they're there. And you guys are spending a lot of money. These courses are expensive for them to be there, and they're just not participating in the class, and the end result is not passing the test at the end, which is a new requirement within the last year for them. And so I'm going to put this charge on you guys to make good decisions about what you want to do with that. I can tell you, if one of my staff members at the hospital didn't pass it, I would have to really think about, do I want them abstracting data for my registry? So that's all I really have to say about that. I mentioned the last webinar that we had that we are putting some surveys together and publishing them on our website for the Orange Book. We are working on a processes to update the Orange, to revise the Orange Book, and we're going to do it by chapter, and we're starting with feedback from you guys. It's chapter 15 where this CD is that going to be the first chapter revised? I don't think so. I think we have some, we're prioritizing that, and I don't think that's going to be the first one. But when the time comes for you to be able to provide feedback by that survey for this chapter, I certainly want you to talk about that, encourage you to talk about your staff that have failed that course, because it will certainly help us make that change. That's certainly what we're going to propose is a change that you have to take it. Not only do you have to take it, you have to pass it. So I hope that helps you.
Thank you, Tammy. So a couple of questions on alternate pathways. So I just want to talk a little bit about this because we did implement a new process for those who have previously been approved by the alternate pathway at the current trauma center. So the rule is that any non-board certified surgeon who trains abroad, either internationally, the words used interchangeably, they must be approved via alternate pathway. For those who have previously been approved at that trauma center, there is a new process that they will not be required to repeat an on-site survey review. The surgeon would need to just meet a couple of the requirements, and we have that published on the website, and I'm going to show it here. So again, the website is listed at the bottom of the slide here, and it's on page 4. So surgeons who have previously been approved by the alternate pathway are, during subsequent visits, they're going to need to follow the following 5 criteria. And I labeled them criteria number by criteria, essentially just bullets. So we just wanted to pick out those that would need to be available at the time of the site visit. So for example, criteria number 2 is bullet number 2 in the document. We just want them to be current as ATLS provider or instructor. They must panel members, TIPS attendants, just like the other panel members, or representatives, liaisons, but they will be required to do this. Documentation of membership or attendance at local and regional or national trauma meetings. And criteria number 7, PIPS for improvement and assessment by the trauma medical director that the M&M results for patients treated by the surgeon compare favorably with the M&M results for comparable patients. So what this really means is that the trauma medical director is performing a PIPS review of that surgeon's case. External CME, and I think what the question here is, and I wasn't too clear on it, but what I interpret this to mean is they're asking if internal CME count towards the requirement to meet the external CME. And if that's not correct, please reach out to me at the COT-VRC at FACS inbox. So my understanding, that was my understanding. Again, if it's incorrect, just reach out to me. The answer is no. Verifiable external CME for the TMD and liaisons are obtained from attending state, regional, or national conferences. Ways to do external CME, but we're looking for external if the question was related to the trauma medical director and your liaison. Another question about CME, so this has to do with new members or new residents or those who recently completed a fellowship. For centers undergoing verification for the first time and our existing trauma centers that have new physicians, meaning recent grads, residents, or new hire, CMEs will be prorated. Ideally, prorated CME should be equivalent to 16 hours annually. Obviously, if they're new to the service, say a couple of months in, they may have just a few hours of CME. That's okay, that's acceptable. I do want to say that if you have any of these types of surgeons, physicians in your service and you're coming up for a site visit, be sure that in the appendix for whichever specialty that may be, next to their name, if you can put new staff or new hire or recent grad, whatever will catch the eye of the reviewer so they know that, going in, they're not already citing you with a deficiency. As you recall, reviewers are looking at this, on their way to the trauma center. They're looking at your PRQ, and they're going to look for things that kind of raise a red flag. CME and research. Question was, how do you define 3 years for CMEs and research? Is it from the time of the consultative visit? Again, in the previous slide, we talked about prorating. If you're a new trauma center seeking verification for the first time or have new hires and grads, their CMEs are going to be prorated. Research is not prorated. It's just something that the committee felt that it's for a level 1. Again, I want to stress this is for a level 1. Research is not prorated. It's based on 36 months leading up to the site visit, so it's within those 3 years. Articles approved but not yet published will be accepted to meet the research requirements. CME non-liaisons. Can educational requirements of non-liaison physicians be met by a combination of internal and external CME hours? Yes. Trauma panel members, what we refer to as non-liaisons, may meet the requirement by having a mix of external and internal CMEs. What I recommend, just to make it easier on the trauma program manager or whomever is collecting this data, and for the site reviewers, to have a summary page for each of the physicians with their hours for internal, what's internal, what you're counting as external, have the subject on there, the topic, the location, the date, and the type of CME that you're counting to meet that requirement. So having that summary page is huge for these reviewers. There's a lot of deficiencies around CMEs, and a lot of it is just a lack of communication, and we're going to try to hopefully make that easier for trauma programs going further. CME courses, someone asked, which is a great question, about what college courses offer trauma-related CME, and if you see here, I've listed them all. Well, not all of them related to our area here in trauma. And I do want to stress for folks that are new to this, if CMEs are relevant to the management and care of the trauma patient, it will count to meet the requirements. What becomes challenging is, well, defining that. How do you define that? How do you present that to the site reviewers at that time? And really having that summary page is really what's going to help. And I recently had an email from someone out west, I think it was, and they brought up a great idea, and it had to do with a particular organization that actually provided a transcript of their CMEs, and that is acceptable as long as it's an accredited organization that provides the transcripts of the CMEs for that physician. We will accept that. This way, you don't have to print every single certificate, so that you can use that. As you see here, ASSET provides 6 hours. RTTDC provides 9 hours, CSAP 6 hours, and DMAP 8.25 hours, and ADAM provides 7.5. The next slide is referencing the ATLS course. For those of you that are in your 3-year cycle, the 8th edition may apply, the 9th edition may apply. Currently, the 10th edition does not provide or offer CME at this time. They're in the process of doing that as we speak. So I just wanted to provide a template for you all to just hopefully to provide some help. So I had a question on residents and postgraduate 4 or 5 and what their role is. So in the book, it talks about a resident in PGY 4 or 5 who's part of the trauma team may begin resuscitation while awaiting the arrival of the attending surgeon. Want to stress that their participation and their response cannot independently fulfill the responsibilities of or substitute for the attending surgeon. The attending surgeon, if you're a level 1 and level 2, the attending surgeon must respond within 15 minutes. So during the site review visit, the medical records will reflect the PGY 4 or 5's involvement in the care of the trauma patient. So the site review team can definitely look at that, and they'll see their involvement. So questions about direct physician-to-physician contact. I know there's been a lot of discussion on this as well. Speaking to one another when transferring a patient. There are some states that have referral centers that have been credentialed to receive and relay the communication to the ED physician or the trauma surgeon. We've said that that is acceptable. There must be clear communication documented for this process, but I just want to make sure that we covered this because there's been a lot of questions whether it can be an APP, advanced practice provider, or it can be a referral center. So we said it's been acceptable as long as there's documentation. Same question about transfers. What is the best answer for transfers out if we do not transfer out for a level 1? So as many of you know, level 1s should not be transferring any patients. I do realize that there are going to be some instances that they may transfer for specialty care such as burns, microvascular, reimplantation in the PRQ. So there's a table that we want to capture who you're transferring or what service they're transferring to, so you want to go ahead and document that. And I also want to make sure that you understand that all transfers out must be reviewed through the PIPS process. That is a requirement, CD 4-3. Several questions about the ongoing professional practice evaluation, CD 5-11. There are a few, I think there's 2 examples on the website, and of course, they're just examples. The trauma center or the institution can develop their own ongoing professional practice evaluation. It can be a scorecard. It can be a report card. Whatever it is that you have available, that's acceptable. Again, there's a few examples, and I do want to talk a little bit about the expectation. The expectation is that the trauma medical director is conducting an OPP, and it has a process scorecard template report available to present on-site if asked. At this time, we're just asking whether or not they're doing this process, they're conducting this. We're not asking, or I should say some reviewers may ask to see a report card or a template, and that's okay. Just be prepared to present it. I also want to talk a little bit about what role the trauma medical director has in this, and there's seems to be a little confusion, so I want to clear it up here, and this is also stated in the clarification document. The trauma medical director is not expected to perform an OPPE on, say, your orthos, your neuros, your, or ED physicians. The trauma medical director should perform an OPP for those specialists or those trauma surgeons and 8 advanced providers under his service, his or her service rather, and the ED physicians, neurosurgeons, orthopedic surgeons should be performed by their respective directors with oversight by the trauma medical director. So everything kind of filters upward to the medical director. Same for the mid-level providers or advanced practice providers or your PAs on the service. If they're on the trauma service, the trauma medical director should do those. If they're on the orthopedic service or the neuro service or ED service, they should be done by their respective directors with oversight by the trauma medical director. There's a question about the focused professional practice evaluation. And what I think they're asking is, well, the question goes, for a new TMD, does her initial FPPE need to be trauma surgical cases, or are non-trauma surgical cases acceptable? Per the requirement, there has to be an annual assessment of the trauma panel providers in the form of an OPPE and an FPPE. So when there's indications in the PIPS process for this, there should be a process to review that, whether they're new coming into the center or if they've been at the trauma center. Limited tier activations. Is the trauma service expected to evaluate Tier 2 activations discharged from ED prior to departure? The trauma activation for the limited tier will be defined by the trauma center. So I know a lot of people are asking us to define a time for when the surgeon is expected to respond. Well, we left that kind of nebulous because we want the limited tier should be defined by the center, and it should be defined based on their demographic area. And what we're asking is that if you're going to define that, to ensure that your surgeon is expected to respond to and having a time frame for them. So one of the requirements of doing this is there must be a continual assessment of the trauma activation tiers to capture over and under triage. That's CD 16-7 in the Orange Book. Several questions about non-surgical admissions, and I know it gets a little confusing the way it's written in the PRQ. And I want to state that having greater than 10% of non-surgical admissions in your trauma center does not constitute a deficiency. What will trigger a deficiency is if those patients, after you remove once you use the formula in %, and the trauma medical director and the trauma program manager are not reviewing those patients greater than 10% through your non-surgical admissions, that's what's going to really trigger the deficiency. So having a high percentage of non-surgicals is fine. It's just reviewing them for appropriateness of care is what we're looking for. So this question is related to elderly with single level falls and hip fractures. Here's what I want to say, and this, hopefully I captured it correctly, or not correctly, but clearly. Isolated hip fractures and or single level falls may be admitted to medicine with a surgical consult. If these patients are captured in the trauma registry, they will count towards your non-surgical admission rate. Now, capturing these patients in the trauma registry are based on your state, local, or institution admitting policy. If they are captured in the registry and will be used in completing the PRQ, your data tables, they are subjected to follow the NSA formula on page 121. So again, if you're greater than 10% after you use the formula, just ensure that you're reviewing those cases for appropriateness of care. Peer review attendance for locums, we covered this a little bit. Are locums included in meeting attendance requirements like staff surgeons? Yes, they are. So locums are trauma surgeons, I mean, we use the word interchangeable, who take partial trauma call are required to meet the 50% attendance requirement. If unavailable to attend in person, again, they can participate by video or to phone conferencing. Trauma program manager. Can a TPM oversee more than one program, such as burns, trauma, and surgical ICU? So what I want to say about this, if it's a level 2 trauma center, the trauma program manager must be dedicated to a trauma program. So, so if there's any other responsibilities outside of the trauma program, we're saying they cannot manage those other areas. So I've seen in some instances where they want them to either do stroke or they want them to oversee the EMS. Those other programs. For a level 3, this is a little different. For a level 3, because they're not full-time or they don't have to be full-time, they can oversee other areas. But for a level 2 trauma program manager, they may have other responsibilities within the trauma program, such as the injury prevention coordinator. This is also noted in the resources guide. There's a table in chapter 5 on page 42 of the manual. Documentation for peer review attendance. How should everyone has a little different way of collecting this data. You know, ideally what you want to do is have either the trauma medical director or the trauma program manager be the one to kind of log the folks in when they call in, or if they're conferencing in. So you can just do a check or electronic signature, if you will, or just like a check mark. I think if you're able to demonstrate that they participated, that's acceptable during a site review. Emergency physicians non-board certified. So they want a clarification on if the ED, MD is non-board certified, can they still evaluate non-trauma activations? If the emergency department physician is not board certified, but is board eligible, meaning they're waiting to take their boards or taking part of their boards and waiting to take the second part of their boards, they can still be active in evaluating trauma patients and respond to trauma activations. With this said, if the emergency department physician is not board certified for reasons of not completing a U.S. or Canadian residency or has exceeded the allotted number of attempts, or to become board certified, or just never took their boards, meaning they're just not board certified and have no intentions of becoming board certified, they can only evaluate non-trauma patients. So the answer is no, they can only evaluate non-trauma patients. A question about orthopedic traumatologist leader. So this is the OTL leader, 9-5 for pediatric trauma centers. So there's a couple ways to meet this. So the question is, how do we answer this in the PRQ? Do we have a transfer agreement in place, and did we submit the questionnaire to ACS, but this fellowship did not exist until 2013? How are reviewers dealing with this new requirement? Correct. So the fellowship process for the orthopedic leader, I think they started recognizing the approved fellowships in 2013. So we have a process in place for those who completed an orthopedic fellowship prior to 2013. And that process is that we have a subgroup of orthopedic committee members, committee on trauma members from the orthopedic group that will review all applicants, or I should say all forms that are submitted for level 1. And what they do is they review those programs, and they have a list that they can go back to and say yay or nay that that is an approved fellowship. So we do track that here internally. And if there is a candidate that does not, the completed fellowship is not approved, they will be notified by our staff. So to answer the pediatric question, so pediatric trauma centers may meet the requirement a couple of ways. So if there's not one on staff, an OTL on staff, they can have a transfer agreement with another trauma center that does have one on staff. There's another way of, if there are combined trauma centers, say an adult trauma center across the street or just part of their health system, they can share OTL resources, meaning that if the adult trauma center has the OTL surgeon on their staff and has privileges over to the pediatric trauma, want you to complete the OTL form if you're going the resources, we do still ask that you complete this form, just because we're just categorization. Orthopedic surgery response. Isolated ortho injury on the ortho service has their NP evaluate the patient. The attending does not evaluate. Is that an issue? It is not an issue. The expectation is for the specialist or advanced practice providers or APPs/residents on that service to respond when the request is made by the attending surgeon. What we want to ensure documentation with the attending specialist surgeon on the plan of care for that trauma patient. Peer review attendance for anesthesia. So a couple of things I want to talk about here. So the question is, can a CRNA be designated alternate for the meeting attendance? In general, the CRNA cannot be an alternate to meet the anesthesiologist peer review attendance. This must be met by having a physician representative. With that said, there are some states that allow, for level 3s, that would allow their CRNAs who are licensed to practice independently to be the anesthesia liaison. This is also noted in the clarification document. So again, for level 3s in states where the CRNAs are licensed to practice independently may be designated as the anesthesia liaison. So there's a handful of those states that allow this. Our referring hospital still the advent of sharing radiology images. No. So the referring center may share via telemedicine or by another imaging source, so they don't have to send it. They can do it, again, via telemedicine or another source electronically. ICU credential providers response. If the trauma surgeon documents in their notes the time this suffice, it does. So the trauma program must track the time the trauma surgeon or consultant was paged, called to the ICU for emergent issues related to the trauma patient, and document the response time at bedside. Any issues or delays in care must be reviewed through the PIPS process by the trauma program. So you have to have a process in place where you're capturing when they were called and when they responded, and track that through your PIPS process for any delays. ICU liaison. Can the trauma medical director also serve in the role of ICU liaison, and what are the responsibilities in this role? For a level 3 trauma center, the trauma medical director may also serve as the ICU or director or co-director liaison. The ICU liaison must be actively involved in and responsible for setting policies and administrative decisions related to trauma ICU patients. So they have to have oversight in the ICU and be involved in the administrative decisions and who's caring for those patients. ICU nursing. So this was a great question. And how is the nurse ratio for trauma patients in the ICU calculated? As you know, the requirement is patient-nurse ratio must not exceed 2 to 1. This is defined as for every 2 ICU patients, there's a minimum of 1 nurse. For example, if you have a 10-bed ICU, you should have 5 nurses to take care of 10 patients. So, so that's a great example there. Surgical specialty care. So I've had several questions about microvascular, which I'll cover in the next slide. Question was, what constitutes hand surgery? And what we've said is hand surgery may be covered by plastics and or OMFS. The capability for reimplantation is not expected for a level 2. Same for a level 1. This can be met by having a transfer agreement. So that's one of those that you're allowed to have a transfer agreement for that type of injury. Microvascular. For microvascular, the expectation is that you have a microvascular surgeon. However, as I know this has been an area of concern for many level 2 trauma centers, we have said that coverage may be satisfied by having a surgeon who uses an operating microscope for nerve repair, free tissue transfer, etc. The microvascular capability is not required to be in-house 24/7, but must be available when the trauma surgeon requests their service. So they don't have to be in-house 24/7. They have to just be available providers need to be current in ATLS. The trauma and or emergency department ED APPs that function as a member of the team caring for trauma activation patients via assessment or interventions must be current in ATLS. If the trauma and or ED mid-levels only role is as a scribe or entering orders, they would not need to meet the ATLS requirements. So we've said this several times over the course of our last few webinars, and it's also, we've updated this language a little bit, as you see here, in the clarification document just to make it clearer for trauma centers. And hopefully it has done hopefully it's been clearer. And I also want to say that neurosurgery and ortho APPs who respond in lieu of the ortho surgeon or the neurosurgeon during an activation are not required to meet the ATLS requirements. So if they're just coming down to consult on a patient that just came in, they're not required to do that. So one of the things that we noticed after we released the clarification document last month, hence why I'm going to do another one this coming week, there was a typo, and I'm sure it freaked out a few people. The classifications and deaths did not change. For some reason, there was just a line through the toxin was incorrect. So mortality with opportunity for improvement, mortality without opportunity for improvement, and unanticipated mortality with opportunity for improvement. So those remain the same, and they will be noted in this coming clarification document. Questions about universal screening for alcohol. Please clarify the questions for experts. So I want to state that universal screening for alcohol use must be that's the CD. In the clarification, we have clarified this as the following. For level 1 and 2 trauma centers, all patients who have screened positive must receive an intervention by an appropriately trained staff, and this intervention must be documented. This means all patients that meet ACS registry inclusion criteria with a hospital stay of greater than 24 hours. Pediatric patients, the age should be defined by the trauma center, and that's what we're going to hold you to. Documentation for universal screening and alcohol. So, be done during the site visit. Ideally, this is going to be seen during the case review section. Depending on your trauma center's process for documenting the expert results, most are either noted in the flow sheet or someplace in the patient's medical record or have available the screening tool report within the medical record. So again, centers capture this differently. There's no right way or wrong way. As long as it's available for review during the site visit, you can, if it's separate from their medical records, just if you can, have a binder or have a loose leaf sheet in the medical record, that'll be acceptable. Interventions. What is the expectation for this? The 100% to be screened and intervention completed before discharge. All patients admitted must be screened, and those that screen positive must receive an intervention by an appropriately trained staff. This intervention must be documented. So the program should track results on those patients that received an intervention or were referred to an inpatient rehab program or a structured outpatient program. This does not mean, the requirement does not mean that it has to be 100% with both the screening and completing intervention. We're just asking they be screened and that an intervention was done. That's what we're asking for. Question on hospital disaster committee. I think this was a great question. Trauma panel surgeons, as a member of the hospital disaster preparedness committee, we ask verification. We are seeking verification. One of our adult trauma surgeons is a member of the hospital disaster preparedness, the PICU. That's great. It is acceptable for the adult and or the pediatric trauma surgeons to be members of the hospital disaster committee. You don't have to have one, you can have two, or you can have one or the other, as long as there's representation from the trauma panel and it's a surgeon on the hospital disaster committee. And that concludes our webinar for today. Thank you for participating.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification September Q&A Web Conference. If you have any other questions, please contact cotvRC@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today, and have a great rest of your day.